Hello and welcome. Thank you so much for being with us. We are going to get started. We have a good number of folks that have joined. So, by way of introduction, I'm Stephanie Glenn. I'm the Chief Commercial Officer here at Maven Clinic. Whether you're new to Maven or one of our beloved partners, here's a quick refresher. So, Maven is the largest clinic for women and families in the world, covering over 23 million people. We are an end-to-end platform supporting preconception, fertility, pregnancy, and menopause with 24/7 access to the largest virtual care network and proven ROI across diverse populations. For over a decade, we've been honored to help people around the world grow their families, and that's why we're here today. So, there are a lot of reasons why you might be here today. Maybe you're a benefits leader looking for tactical guidance on the new fertility changes from the White House, or maybe an HR professional hoping to better understand these changes so that you can answer questions coming from your own workforce. And some of you might be patients yourselves, feeling pulled in every direction as you try and understand your own care. I want to make one thing clear. This webinar is for all of you. It's not every day that the White House releases new policies about fertility care, and there's a lot to talk about. So I am thrilled to have my partner in crime, Maven's Chief Medical Officer, Dr. Neel Shah, with us today. So maybe let me do a little humble brag about Neel and how he is very equipped to answer my tough questions today. So Dr. Shah is an academic OBGYN by training. As a faculty member at Harvard, he wrote more than 100 peer-reviewed academic papers, contributed to 4 books about how we can better serve pregnant women and families. He is globally recognized he is a globally recognized expert in designing healthcare systems that truly meet women and families where they are. And his work to build equitable, trustworthy systems of care has been profiled by the New York Times, Good Morning America, and other outlets. And he was named, I love this, he was named among the 40 smartest people in healthcare by the Becker's Hospital Review. Beyond his medical training, he also holds a master's in public policy from the Harvard Kennedy School. He is, in other words, the perfect person to be what I'm going to call our policy doula through this process. So thanks for being here, Neel.
I love policy duo, by the way, and it's always funny to be formally introduced by a close colleague. I hope to return the favor for you someday, Stephanie.
I
Yeah,
would I would love it. Okay, so let's start at the top, Neel. What brought us here? Like I said, it's not every day that the federal government wades in on our world and weighs in on fertility benefits. What led to this?
yeah. Well, I mean, as most of the people on this call probably know, we've been anticipating some kind of announcement for a while. Back in February, the White House issued an executive order called Expanding Access to IVF. And executive orders are not always the same thing as public policy. Sometimes they're just a statement of values. So this particular executive order didn't direct the agencies to do anything. It actually just told the Domestic Policy Council to come up with a set of recommendations, which is what we heard last week and we'll get into. But in this case, the administration started by just sort of stating they value making it easier for families that are battling infertility to have children, and that they want to do that by making IVF more accessible, both financially and logistically. And so last week, they shared the policy suggestions publicly in a press conference along with a fact sheet. And I caveat that because there's still rulemaking that needs to be done and things that need to be formalized. There's a lot of details that are still being worked out. But it's the clearest picture we've had so far about what is likely to come in the new calendar year.
Right. So let's break it down. What did the White House actually announce last week?
Yeah, there's two pieces to this. The first part got most of the attention, which is the cost of medications. So medication costs are going to come down as soon as January 2026 for people that are paying cash for fertility drugs. And so they announced a partnership with EMD Serrano where they use the purchasing power of the government to directly negotiate down the prices of many of the most commonly used and expensive medications, like Gonal F, for example, for people who are deep in the weeds. These are medications that can cost like $6,000 per cycle. And for many Americans, they're going to means test based on income. But for people that make up to 540% of the federal poverty limit, the cost can come down by half. So thousands of dollars per cycle. We've also heard directly from the PBMs that they will be honoring this pricing as well. This will not immediately affect employers who already offer medications through managed care benefits, But given the very stark difference between $6,000 per cycle and $3,000 per cycle, and another twist that may lower them even sooner, which we'll probably get into, the full expectation is that um, prices will come down substantially across the board. So that's the first part of it, and there's a lot of nuance that I'm sure we'll get into. The second part of it, which has gotten less attention, but is equally important, is that they said that federal benefits should look more like dental and vision benefits, carved out for major medical. Many of you who are on this call have already chosen to take that approach. Some of you are sort of exploring that approach. But they clarified what that really means in terms of the flexibility that employers have to design benefits that make sense.
Right. Okay. So in plain terms, these changes could make the IVF medications cheaper and change how employers are thinking about designing fertility benefits.
That's right. And, this is important. None of this has taken effect yet. They signal direction. They're not necessarily regulation in all cases. But we're closely tracking what this means for our clients and our members. And we do fully expect and are anticipating and planning and building for a world in which uh, all of you who are listening have more flexibility in benefit design, and you will see a difference in medication pricing.
Awesome. So let's dig a little deeper into what these new federal actions really mean. When you read the policy fact sheet, there's a lot of jargon, and I think people are wondering what's actually changing in practice.
Yeah, okay. So let's start with the medications and how they fit within what IVF is. So IVF can cost $25,000 per cycle. And by cycle, we mean, there's a fertility cycle that's like monthly, and each cycle is your crack to try and get pregnant. And for many people, it takes multiple cycles to get to their actual goal, right? Most people do not want IVF specifically. They want the shortest pathway to a healthy baby. But every one of these cycles um, costs approximately $25,000. And a third of that cost is the medications. So the medications are used to stimulate a woman's ovaries so they release multiple eggs, which increases the odds of one of those eggs being viable and leading to a baby. Um, the medications, I should also probably mention, for other medication classes that are top of mind for many of you, like GLP-1s, there's a long pipeline of new molecules coming online and new indications. IVF is about as old as I am. The first IVF baby in America lives in Massachusetts, and she's exactly my age. And we have not had new drugs since the 90s. And so uh, the prices have been what they've been. And it has allowed the manufacturers to increase the prices year over year. And so that's part of the changing dynamic. The White House agreed with one of the two major manufacturers, EMD Serono, to reduce the cost of three very common medications by 20 to 40%. So for patients, this means thousands of dollars of savings per cycle, potentially right out of their pocket. For employers, this will likely translate directly into lower claims cost when fertility benefits are in play over time, potentially even within the year. The other plot twist, which is sort of interesting, is that there is another medication that's used by not EMD Serrano, but their competitor, Ferring, that is used in most IVF cycles and has not had a competitor for a while. But there's a European drug that the administration has decided to fast track through the FDA. This is rarely done, so people who are familiar with the FDA are used to things taking a long time. But the White House signaled that in a matter of months, they may bring this to market, and it would again lower the cost of that approach by thousands of dollars.
Right. So that's on the drug side. And then on the plan design side, break it down.
Right. Okay. So you have your health plan, and then you have vision and you have dental. And the reason to also carve out fertility is that fertility breaks a lot of the rules of a standard health plan. Um, One top of mind example is like generally speaking, a health insurance company won't pay for something without a clinical diagnosis. But if you're a same-sex couple, you don't have a clinical infertility diagnosis necessarily to benefit from these kinds of benefits. So carving out provides that kind of flexibility. The other thing, though, is that typically, even in carve-out models, you have to meet your deductible, for example, which can be substantial, as many of you know, to access treatment. And the kind of flexibility they're providing is, for example, to provide first dollar coverage for fertility. The other thing that's really important and very aligned to our thinking at Maven, the traditional fertility benefits, um, they work through marking up the costs of treatment. And you see that reflected in the stock price of a publicly traded fertility benefits company last week when there was a massive sell-off because if fertility drug prices are coming down, then they lose money on what they can mark up. That has not been our approach. Our approach has been to pass costs directly without any markup um, to our clients, but to also, alongside administering the benefit, manage care at the same time. And the White House is really clear that they think that that's the right approach. And the best analog I have for this is that in the MSK world, in orthopedic surgery, you wouldn't only pay for the surgery. Right. The whole reason that you also pay for PT and MSK solutions is to avoid the surgery in the first place and to make the surgical costs go down. And right now in the fertility world, many people are only paying for the procedure and they're not managing the population of people who are trying to conceive and helping them avoid needing the procedure in the first place. And the White House is very clear that they think within this accepted benefit, you should also cover that approach.
Right, right, right. Okay, so we now know what's coming, but nobody likes to wait around. And we know there are a lot of A+ students on this call who want to know what they should be doing right this second. So for the folks that are joining us who are already part of Maven's fertility programs, what should they expect in the near term?
Yeah, I mean, I think time is of the essence. So I think it's important to be planful. The good news is I think this is a mix of folks who are Maven clients today and people who may be considering adding benefits like this in the future. If you're already a Maven client, you're well positioned to adapt to these changes. And as I mentioned, through Maven RX, which is our approach to medications, we work
I think we might have lost Neil.
the cost, all rebates in this system of ours.
We lost you for 1 second. So start with that Maven RX.
Okay, so we are going to continue to just pass our negotiated prices back to employers. That is our approach. That's our way of doing it, including rebates. They'll go right back to the employer and to the member. Um, these cost changes in the immediate term will affect those that are cash pay. As I mentioned, the managed care costs will also go down. Um, and I also think that because we're a digital benefit, we're sort of uniquely nimble to adapt to additional guidance and changes because we have the technology to move fast. We don't have, sort of calcified processes and that kind of thing. And through our health plan and PBM partnerships, we're also deeply integrated with the industry. And in fact, next week, we're at the largest fertility meeting in the country and plan to spend much of it directly speaking with the pharmacies, the manufacturers, the health plans, and the other partners in the ecosystem.
Yeah, that's huge. And I'm looking forward to being there for those of you that will be at ASRM. So for employers that don't yet have Maven, maybe they don't have a fertility benefit at all yet, what's your advice?
I mean, you should start prepping now, which you are, because you're interrupting your workday to come and listen and think about this. I mean, right now, there's a clear sign from the administration, carve out fertility benefits, drive down price, and lead to better outcomes. And they offer a better patient experience. And so that's why they're endorsing it. They did their diligence. And, there are many approaches to covering IVF. They considered it for a period of 9 months, and they came down to the conclusion that carving it out is the way to go. So if you don't have a carve-out benefit today, it's a good time to reevaluate your strategy. And of course, we're happy to be available and help you thinking that through. Our own benefit is designed to be turnkey. So, it's clinically sound, it's inclusive, it's easy to launch, whether you do it directly or through one of our health plan or PBM partners. And employers who add coverage now can be ready to leverage the upcoming policy shifts without scrambling when the rules are finalized, because we're sort of tracking in real time.
Yeah. So let's bring it back to our own North Star, which is always the patient. You have this great quote about how sometimes healthcare policies feel like they've been made by astronomers looking through a telescope at the world the rest of us actually live on. So let's bring it back to these real people. How do these shifts show up for a patient or an HR leader trying to support someone going through IVF?
Sure. Well, back when the executive order was first announced, uh, my team and I did a deep dive into the nuances of how people end up getting sticker shock and IVF. Not just the fact that the prices are high, but there are all of these hidden costs. So we wrote an article called "Priced Out of Parenthood," where we like unpacked all this. And in that um, work, we talked to a patient named Beth. And so Beth's story is like a very common one, so I'll just tell it briefly. This is a person who'd been trying to have a baby for over a year, right? And as a human being in 2023 or 2024, whenever it had been, she had to like wince through all of her friends' baby showers, right? For her former bridesmaids, a tearful call from a sister-in-law who was now expecting like her third baby, all of the Instagram pregnancy announcements that she was inundated with. And it seemed like everybody could get pregnant but her. And also, this is the thing about being pregnant or trying to be pregnant. Everybody had opinions on what she should be doing. And when she decided it was time to get medical help, the nearest fertility clinic was booked months out. And that's the common case for most Americans. You have to wait a minimum of 2 months. Then she finally goes there, and she's like, a very planful person. She knew her benefit and her options, and based on her clinical situation, she'd been trying for a year. She was 34 years old. They told her it was time to start thinking about IVF. Um, and even though she consulted her health insurance, and even though her health insurance said that she would be covered for 2 cycles, there was a catch, which she did not know until she was at the front desk of the clinic when they explained to her that while her treatment was covered, the meds that facilitated it were not. And one can't proceed without the other. So, of course, that was devastating. And it meant she had to wait to start trying until um, she made other trade-offs in her life, right? These are really material things. And we have data at Maven that says that um, 70% of people incur debt and make really substantial life trade-offs between mortgages and education and other things to do this. Um, so, this is a person who'd done everything right, which is why I think it's so poignant. She ordered her choices, she did her research, but she didn't have like $6,000 lying around. And that was the difference between being able to realize her dream of starting a family and not. And so, when we talk about the impact of these changes, we're talking about people like Beth.
Yeah, thank you for sharing that. Just two last questions, and then we're going to go ahead and open it up. So if you have more questions, you can put them in the Q&A bar at the bottom of your Zoom screen. But I think everyone on this call probably knows a Beth or has been a Beth, and she's why we do what we do. So let's turn it again to the benefits leader who can help impact that end member or patient. What should they be doing this quarter to prepare for what's next?
So now everybody is on high alert, so continue to stay informed, and Maven intends to be a channel for you to get the latest updates and understand our interpretation of what we're seeing and what we plan to do about it. Um, at the same time, in parallel, you should audit your current benefit. Make sure that you understand what fertility coverage you already offer. Do you carve in? Do you wrap around? What are you doing? And what would a managed benefit look like for you, given that that's the administration's preferred approach and the benefits are more clear now based on the evidence? Lean on the experts. There are a lot in the ecosystem. There's brokers, there's consultants. Um, Vendors like Maven can help you stay compliant, leverage new pricing models. And one of the things that I really take seriously is the way in which we're able to partner to design benefits that support your employees because they necessarily need to be flexible based on differences in your population and your specific needs, and we're always happy to think about that. And then the last piece is your employees are watching the news too. People that may need IVF are people that usually are thinking ahead about it. They may have even chosen you as an employer based on the benefits that you offer. So just make sure that you communicate early and often about what you're seeing.
Yeah, that last one is key. And we actually drafted some sample employee language that HR teams can use. So we'll drop that in the chat. The quote being, you'll continue to have access to fertility care, navigation, and coaching through Maven. As new federal guidance and medication savings take effect, we'll integrate those changes into your benefits if applicable. So we'll definitely stay along with you in terms of that comms plan.
Yeah, change is always hard, but building a family is existential for people. And so transparency builds trust. And our aim at Maven is to be really clear about what we know for sure, what we think is going to happen and why, and also what we don't know.
Yeah, the empathy and honesty go a long way. Okay, last question for Neel, for you, Neel, which
Yeah.
I'm sure we could spend hours talking about. But what's your take on what this means for the fertility industry in general?
Yeah, I mean, I think we're living at a historical inflection point. I mentioned that IVF is as old as I am, which doesn't feel that old. And
You're not that
only
old.
Thank you. I appreciate that, Stephanie. We're about the same age, so I appreciate that. But like IVF right now, only 3% of pregnancies come via IVF, but the waiting line of need is 5 times longer. And that's why it caught the attention of the administration because there's so much demand for all Americans across the whole country, whether they're in Alabama or Massachusetts or California. Um, so it's clear to me that within the next calendar year, drug costs are going to come down. By how much is a little bit TBD, but substantially. I will say that I know that, not that I think that. That more inclusive benefit designs are going to be realized. And by the way, what that really means concretely for you is that within the dollars you're already spending, you can make them go farther. So when we talk about benefit design, that's what we're going to talk about. Um, you can help your employees get more out of that. Um, and it will take employers leading the way. I think that's the other thing is that employers are the ones who conceived of carved out fertility benefits that now the administration is amplifying. And so you have an opportunity to support your employees that are reproductive age, be their best selves at work, and also realize their dreams at the same time.
I love it. Okay, we have a ton of questions. Let's see how many we can rapid fire get through. And if not, we're happy to follow up with some of the questions. So just again, reminder, use the Q&A feature if you do have questions. And here we go, rapid fire style. Okay, so does the medication that makes up a third of the cost, does that include progesterone or when the cycle is successful, or is that separate?
We're mostly talking about the ovarian stimulation medication, so not progesterone, but things like Menopur, which is the Ferring medication, and Ovidril, Gonal-F medications like that.
Got it. You already answered this, and it's a little crystal ball, but should we expect to see lower drug costs in January of 26, or what's your best estimate on timing?
Um, well, I cannot control the future, but the administration has said that in January 2026 is when the cash pay rates will be in effect.
Okay, perfect. I can help answer this one, but I'll let you start. Does Maven offer carve-out fertility coverage that would cover the cost of IVF?
Sure does, but why don't you take this one, Stephanie?
Yeah, I mean, we this is a big part of what we're after at Maven, and we have multiple options, everything from family building through a fully carved out solution called MMB or Maven Managed Benefit. If you send me a quick note right after this, we'd be happy to set up time and take you through all the optionality. And as Neel described, I think the benefit design becomes a big piece in terms of how you, as the employer, want to approach this with your employees. What does that coverage look like? And again, really, what are all the wraparound care models that go along with it, especially around natural conception and the full journey to parenthood, which isn't just IVF. Anything you want to add?
Well, just like, in 5 years' time, which extends beyond the current administration, carving out fertility benefits will be standard of care. I'm fairly certain about that. About a third of employers are already there, which is sort of the anchor, but it's clear that this will accelerate that trend, and the trend exists for a reason. Because we want to provide coverage, but we also want to make sure that we're leading to good outcomes and we're creating value at the same time.
Yeah, great. Thank you. How do you think this will impact drug costs for egg freezing since the drugs used to stimulate the release of eggs are similar?
Yeah, it should have the same impact in lowering the cost of treatment by thousands of dollars per cycle. So
Okay,
no
perfect.
different there. Yeah.
Most vision and dental benefits have a max benefit, say $2,000. Is that what you think it could be for fertility?
Well, you have flexibility to design this how you want. The government doesn't dictate whether or not to do it through a lifetime max or through what we call a cycle-based design. This is a little bit into the weeds, but both methods have different advantages. We like the idea of a cycle-based design because it bundles the services together. and it makes it easier for your employee to have a sense of what is likely to be covered or not. Um,
Yeah. Definitely. And then takeaway there, which is definitely reach out to the Maven team and we can help work with you on best practices and what we've seen, both on the sort of like true cost efficiency end of the spectrum to, most robust set of benefits. And we'll share sort of what outcomes we're seeing in those regards. Okay. If employers have a dollar limit in place for coverage for fertility, two questions. Would the employer see a reduction potentially in the RX costs through PBM? Starting in January 26. And I'll let you answer that.
not likely immediately. I
Yep.
think that is likely to follow. Exact timing TBD. But again, like if the managed benefit price is double the cash rate, that can't sustain, especially given the fact that across America, um, most people are paying the cash rate. So that is just the laws of economics are going to pressure that price down substantially. And we're having direct conversations with the manufacturers about exactly where that'll settle out.
Yes. Lots of conversations next week. And second question, when and if the employee surpasses the dollar limit, then would they be considered someone paying cash since any fertility needs beyond their limit would be 100% their responsibility?
That is a really good question. I do not know with certainty. I would imagine yes. But that is a really, really good question, and we'll take that back and follow up with you directly on that.
Yeah, absolutely happy to follow up. If a Maven member goes to purchase their RX from Trump RX, will they be eligible to receive reimbursement through their Maven program and benefit?
Potentially. That's one of the things that I think we're also seeking clarity on right now. Uh, Historically, the answer has been yes, but that could also be like a moving thing. So the short answer is I'm hopeful that the answer will be yes, but I don't know with certainty, and that's something we can come back to you on.
Yep. Agree with that. Hold on, if you carve fertility out from the medical plan, would you be able to allow a gay man to use the benefit to cover treatment on a surrogate in order to grow his family?
Yes. This is
Yes.
the kind of flexibility exactly that a standard medical plan would really struggle with. They don't have a way of contemplating surrogacy or needing donor gametes and sperm and that kind of thing. And so, creating that kind of equitable benefit is exactly one of the major advantages to carving out.
Yep. Would we anticipate these standalone fertility coverage offerings to be in partnership with traditional health benefits, i.e., an additional offering via UHC or Blue Cross Blue Shield? You can start and I can follow.
Yeah, this seems like a shared one. I mean, of course, this one's a little bit crystal bally too, but I think what Stephanie is likely to say is that we partner with 15 health plans and multiple PBMs, and the reason we partner with them is because they're not structurally set up to do this, and we are, and so there's a real complementary um, relationship there.
Yeah, absolutely. And just, again, crystal ball, we're making a lot of progress. We have a lot of great deep partnerships with the channel payers and PBMs, and you can expect to see more from us, especially in the fertility space. Do you anticipate there being any federal requirement? Moving question here. Federal requirement for some level of fertility coverage under employer-sponsored plans?
It's a good question. I think a lot of people were anticipating that that would be part of the announcement. It wasn't part of the formal announcement. I will say many states have taken the initiative to do so, like California, very notably. And the full expectations is that many other states will follow California's lead. Of course, there were states that predated California's initiative too, but my sense is that that will probably happen at the state level in the near term. But there is a lot of advocacy and lobbying interest to write that in at the federal level.
Yeah, so we're right up at time. Neel and I are going to stay on and answer these last five questions. So we're happy to stay on, but I really just want to, if anyone does need to drop at the bottom of the hour, we want you to rate the webinar before you leave. And we really want to say thank you. Obviously, this is happening in real time. A huge thank you to our marketing and comms teams who literally pulled this together within days of the announcement. And you can expect Maven to really continue to be out and forward and communicating as much as possible. So thank you to those who are dropping. And for those that want to stay on for the last questions, here we go. You mentioned a publicly traded company took a hit. I currently offer that benefit to our employees. Can you explain why Maven is set up for success better? I'll let you start, Neil.
Yeah.
Way to follow.
Yeah, there's really two things that happen, but the main reason they took a hit is because that's a business model that depends on drug prices being high. That's a structural thing. So if drug prices go down, it impacts that business. We don't have that business model. We don't mark up the cost of drugs. We are agnostic to the amount of drugs that are prescribed. What we want is the shortest pathway to a healthy baby. So the Maven approach, which is also what the administration endorsed, is to manage the care of everyone who's trying to conceive. And if they need a $5 thyroid medication to conceive, we give them that instead of a $25,000 IVF cycle. If they need support tracking their cycles and knowing when their ovulation window is, we do that to help them get pregnant faster. Um, and if they need IVF, we expedite their pathway to IVF and we make sure that we've negotiated the best possible rates for them. But that is why we're set up for success.
Yeah, I think it's great. Thank you for answering that. And then just even more specifically, about 30% of individuals who come in through Maven Fertility Solutions end up naturally conceiving in some way, shape, or form. And so it really is kind of core to our policy. And then again, just really helps in terms of our business model, not being tied to the markup or of the drugs or the clinics. Okay, can you elaborate on what the full benefit journey can include outside of IVF and other procedures? Has the administration provided any clarity on what that would look like to see included here? Or
Yeah,
what
they
they would
said
like to see included, sorry.
yes, they have. Maybe not comprehensively, but for example, it turns out half of fertility issues live with the male. And right now, a third of IVF cycles are happening without the male ever being tested. So coverage of male testing and fertility services is part of our own benefit design at Maven, and that's something the administration has endorsed, which is we send testing kits at home for men to get tested, and they're relatively inexpensive, and we cover that within our benefit. But it turns out $1 spent on male fertility saves $2 off the cost of IVF, as an example. Um, we have a service that we call conception coaching that nobody is shopping for. But when we offer it to people who are trying to conceive, 90% of people opt in, and they're 55% more likely to conceive naturally as a result of getting that cycle tracking support and metabolic support and other things that set them up for success. So those are some of the examples. But more broadly, IVF isn't the only way to help people get pregnant. There's a set of lower intensity treatments. There's IUI. That's another thing that we see at Maven is that people for whom it's appropriate are much more likely to get pregnant via IUI. So those are the benefits of not being incentivized to drive as much IVF as possible, and that's why the administration wants a benefit approach that keeps all of that in mind.
Yeah. 100%. Oh, this is a topic we've been talking about a lot, Neil. In California, we have a new insurance mandate going into effect for IVF coverage, SB 725, 729. How will Maven integrate into a carve out with a fully insured California plan?
Um, we just will. We're fully committed to doing it. We're in active discussions right now about what that will look like specifically, but it doesn't. Um, I could be missing a nuance here, but I don't think it from a product perspective or from a benefit design perspective, we don't anticipate it being any different than it would be for a self-funded employer. We're taking the exact same approach. And part of the reason is that it's always been a value-based approach, right? In the fully insured space, you really care about making sure that you're producing the best possible outcomes at the lowest cost. And that's good for everybody. And so that is the approach that we've taken.
Yeah. And then the final question, which again, I think we got to a little bit, but how do these changes impact Maven RX's business? Wouldn't prices coming down have a negative impact on Maven RX? And the answer is no, because we're doing a complete straight pass through. So we're not taking any markups.
Correct. Yeah, we never have and we never will.
Perfect. Okay. So you have 110 of you hung on, by the way. So Neel, there was a lot of interest in still hearing what you had to say. Any final thoughts of things just wrapping up, Neel, that you wanted to make sure we just said on the way out?
No, we've covered a lot. This is an opening gambit and also an invitation to connect with us. We're happy to think more about it. And I think in auditing your own benefit, we're also happy to answer questions as you get into the weeds a little bit, because I know that this is complicated.
Yeah, perfect. Neel, Dr. Neel, top 40 health expert. Neel, thank you so much. Please rate the meeting and we'll talk to everybody soon. Thanks again.
Thank you.